This is Dr. Seth Gamrad from the University of Southern California demonstrating the docking technique of ulnar collateral ligament reconstruction for a throwing athlete with a UCL tear. Principles of this technique, first and foremost, begin with indications. We'll do this surgery on a throwing athlete with an MRI demonstrated complete UCL tear. A throwing athlete with a partial ulnar collateral ligament tear, we'll try biologics first, PRP or bone marrow concentrate, plus 3 months of non-operative treatment, including a throwing program. If they fail, they'll go on to surgery. Rarely we'll do this operation on a non-throwing athlete with a UCL tear with persistent pain and instability. Positioning is going to be supine on a hand table. We're not routinely doing arthroscopy unless there's a posteromedial osteophyte or loose body. Graft choice is Palmaris most of the time if you can mark it in the pre-op area. And a quarter of the time we're doing gracilis. The main advantage of this technique versus the modified Jobe technique is that we avoid doing a routine ulnar nerve transposition, and both techniques are going to be successful 85 or 90% of the time. Sequencing, we'll do the graft harvest, find the medial antebrachial cutaneous nerve, split the flexor, split the UCL, and then expose the sublime tubercle. We'll do the ulnar tunnels, pass the graft, do the humeral tunnel, then the suture tunnels, dock one limb, recut the other limb, dock the second limb, and then tie in 30 degrees in varus. Here we are, we're supine position on a hand table. I do my Palmaris harvest through a single incision distally in the flexion crease that makes the most sense. And I've marked this Palmaris in the preoperative area. It's very important. If you can't demonstrate a Palmaris on your athlete's hand in the pre-op area, I go straight to the gracilis. If it's readily demonstrable, you can see I've marked it pre-operatively, and as soon as you cut right over your mark, you're going to find it immediately in the subcutaneous tissue. So here I'm freeing it up distally. I'll switch the scissors to a small right angle clamp, and then we'll suture a 2-0 fiber wire suture into the distal aspect of the Palmaris. Once I've got control over it, I'm going to cut it distally, trying to get as much length as I can. So I've cut the Palmaris there distally, and now we're going to use a special Palmaris harvester. This is a 3 millimeter harvester that the hand guys use to harvest the Palmaris. It's blunt, and so it can be used very effectively without doing any counter incisions. So here I'm sliding it all the way up the forearm, and it's going to release just like a hamstring would up more proximal in the forearm. You can see that's an excellent graft. Once we've done that, I'm going to resuture one end of the graft with O fiber loop suture. This is very convenient for preparing the docking ends of the graft, and it's a very strong suture that we can use for our final fixation. So once we've done tagging one end of the graft with that fiber loop suture, we'll go ahead and set up our incision. I've marked out the ulnar nerve here, and the circle is the medial epicondyle. This is not an operation to do through a small incision. We need to have excellent exposure, and one of the mistakes you can make is trying to do this through a small incision. So we'll dissect out the subcutaneous tissue, paying attention to where the medial antebrachial cutaneous nerve is, and I do this under tourniquet control. Typically takes me around 70 to 90 minutes. So you can see we've exposed the underlying common flexor tendon, and you can see distal in the wound is the medial antebrachial cutaneous nerve. There I'm showing the medial antebrachial cutaneous nerve there with the Addison. We'll dissect that out a little further, and this nerve is going to be way out of our way. Once we've got that nerve taken care of and controlled, we're going to split the flexor. This is typically at the junction between the anterior 2/3 and the posterior 1/3. That puts you nicely right over the top of the anterior band of the ulnar collateral ligament. And I use a combination of blunt and periosteal elevator dissection to split the flexor. We'll take this periosteal elevator and start near the medial epicondyle and split that flexor down to the underlying ligament. So here we've carried that flexor split down to the native ligament, just clearing off the soft tissue overlying the ligament. And once we're down there, I like to use these small cricket retractors from the hand guys to hold the flexor split open. Next step is going to be to split the native ligament. So I start distal on the sublime tubercle and then come proximally all the way up to the medial epicondyle, trying to split it in the center of the ligament. Once that's been split, I have my adson here inside the joint. You can see the joint line is about a centimeter or so distal to the medial epicondyle. Now I'm putting an Army-Navy more distal. We're going to work on exposing the sublime tubercle. I do this sharply with a 15 blade. This area is a little bit unforgiving with a bovie because your ulnar nerve is going to be right within that posterior aspect of this flexor split. So you can see we're clearing off the sublime tubercle and deciding where to make our ulnar tunnels. Now at this point, I try to make sure that you're not too proximal, not too distal with the ulnar tunnels. If you get too proximal, you're too close to the joint line and you run the risk of your tunnels breaking in. If you're too distal, then it's very difficult to get spread between your ulnar tunnels. So I think for me, it's usually about 8 or 9 millimeters distal to the joint line. And we'll go ahead and start here with 3.5 millimeter drill bit and guide from Arthrex. And do that posterior tunnel first with this guide protecting the ulnar nerve. And then we'll do the anterior tunnel second, trying to get a centimeter of spread between the ulnar tunnels, although 8 or 9 millimeters is certainly acceptable in cases as well. Once I've got those two tunnels created, I'll use a curette in each hole. Once I feel like I'm connected, I'll confirm that by making sure the two curettes touch underneath the bone bridge between the two ulnar tunnels. I'll use this little looped wire passer to pass a suture. Through the ulnar tunnel. So that I've got control of those ulnar tunnels. So once I've passed that suture, I go ahead and pass the graft at this point. I feel like it's exposed, you've just worked on it, and the graft is going to be fine sitting there in the wound while you work on the humeral tunnel. So we can see we've passed our graft through the ulnar tunnels, and the graft is going to be just tagged and passed for later. So next we're going to carry the dissection up to the medial epicondyle and prepare a 4.5 millimeter space so that we can drill a 15 millimeter tunnel up the long axis of the humerus using a 4.5 millimeter drill. So we finished that drill hole. Now I'm going to mark a couple of places above the medial epicondyle where we can drill small tunnels for our sutures to exit after the graft limbs have been docked. I'm using a freer elevator. And again, you want to have a centimeter of spread at least. And I err on the side of making those tunnels relatively anterior. Arthrex has an excellent guide that shoots a drill bit straight down into your humeral tunnel and makes this step easier than it used to be. So you can drill that anterior tunnel and then drill that posterior tunnel. And this is a 1.5 millimeter drill bit, and it aims it right into that humeral tunnel, so it makes sure that these tunnels are always connecting. Okay, once those two tunnels are complete, remove the guide. There's a nice little sled here. And we'll pass a suture wire through one of the small drill holes at the proximal aspect of the medial epicondyle for later passage of the graft. We'll bring one suture out. Pass that second suture. Now we have all our tunnels drilled and we're ready to dock one limb of the graft. Before we dock that limb of the graft, I like to take 2O or O fiber wire suture and close and imbricate the native ligament as best I can, making sure I don't block passage of the graft, but I want to make sure that that native tissue is repaired and tightened up as best I can. You can see we've zippered up that split that we previously made in the ligament. Now we'll go ahead and take one of those loop sutures and dock the anterior limb of our graft into the tunnel. So that should bottom out in the tunnel. Now we'll bring the other graft limb up, measure and mark it 1 centimeter away from the entrance to the tunnel. That gives it 5 millimeters of play, so that once you cut it off, it's not going to bottom out and be loose. So I'm going ahead and I'm truncating the graft. Another option is to take that limb and swing it back down after the second limb has been docked. That's been described as well by Dr. Elatrosh. So we're resuturing this second limb of graft with O fiber loop suture, and we'll dock that second limb, and you can see it gets nice and snug without bottoming out in the base of that tunnel. So now for the final fixation of the graft, I have my assistant hold the elbow in 30 degrees of flexion with a varus stress so that we make sure that those graft limbs get tight. And then we tie the sutures from each limb of the graft over the top of the bone bridge on top of the medial epicondyle. Now this is fiber wire suture, so you can get a little bit of a knot stack here. So once I'm done, I'll usually close some soft tissue over the top of the knot to make sure that it's not prominent. Here's a final picture of our graft. Just expose it a little bit better here. You can see it's nice and tight. 2 limbs spanning over the top of your ulnar collateral ligament. So here I am, I'm closing that fascia overlying the knot stack. Once that's closed, we'll close the flexor with 2-0 Vicryl. Don't need to close the muscle itself, just the fascia overlying it. And I'm always surprised at how well and pain-free that this flexor split heals after a few weeks. Thank you.